大家能看得到这个视频吗？能看得到吗 ？Everybody
到了就
看得到是吧？没有啊，
没有了是。
没有东西啊。啊，那我再看一下。
Just it's important to remember.
听不到声音呢？听得到吗？没有，
看到了是有到
能看得到吗？没有啊。
能看
哦，我再看一下。这个嘞，看不看得到？现在可以了。OK OK。Okay, this class will continues. The last class 上一节课 we will start with understand we are studies the pediatrics 什么我们儿科学的一个范畴啊，然后一些分期difference 的 ages 不同的年龄段的一个分期，然后我们一些研究的一些内容啊，这个是上节课的一个this class 啊，这节课的话 we studies the first we together and study looking this is the areas 啊，就是讲了这个视频怎么样讲的，就是我们什么，就是我们儿童的一个心脏的一个啊，就是 because the children's the categories is more and more important 啊，非常重要的一节里面，我们大家一起来仔细听一下，看这个他从他的心脏的一个什么一个生理生化啊，从他的临床表现这些给大家一起来讲习的啊，讲的一个，大家先看一下，我们先一起来学习一下这个视频，我下载下来了 ，OK。能听得见吗？声音小不小？声音小不小啊？我刚才放的，小的话我再给你们调大一点，最大的声音了啊。
A layer sac that surrounds the heart. It has a lot of good functions. So this layer is the outermost layer. It does contain the heart and the great blood vessels surrounding the heart. The inflammation of it, of course, when they end again, ITIS, that's an inflammation of the pericardium. Now, the pericardium has a great function. It fixes the heart, keeps it in its shape, in its position, prevents the excessive dilation if there's no reason for that. And of course, there's a lubrication that needed between systolic and diastolic set. That's important. There's about 10 to 15 milliliters of fluids in the pericardial sac. And when that number is that number increases, that's when the problem is. And also protects the heart from infection, especially from the surrounding area, if lungs infections or any infection in the thoracic area. Now, what is the significance of this protective or protecting sac when it's inflamed? It will restrict the heart movement. And of course, the larger the inflammation, the more restriction it will imply or impose on the heart, and it can be acute or chronic, depends on the etiology. So again, think of it as, again, this is the cover, this is the coat of the heart, and if this coat become very thick, become very inflamed and hard, then it will restrict the movement of the heart, mainly during the systole. So you can think of that the preload will be low, the cardiac output will be low as a result of low ejection fraction. The heart sound will be also muffled, and basically anything that results from the heart movement will be restricted, whether it's the cardiac output, whether it's heart sound, whether it's the contractility, and so on. So keep that picture in mind. In conditions like uremia, for example, again, whether it's infection or whether it's something metabolic, the problem here is the fluid will move from the blood to the surrounding area and cause the inflammation or the edema of these heart layers. So an infection, for example, there's an immune reaction to that. The immune reaction includes, influx of neutrophils, and also in case of metabolic instability, it changes the blood concentration. And whenever the blood concentration changes, the osmolality of the blood, there will be an exchange, and the fluid will shift from the blood to the surrounding area, causing the inflammation. So let's look at the pathophysiology. So etiology could be, again, a viral infection, bacterial infection, neoplasm, uremia, anything that can change the osmolality of the blood, and that can lead to inflammatory response where there's an influx of neutrophils and other chemical mediators. These chemical mediators and the presence of neutrophils will change the permeability. That's a key word. We see it in a lot of inflammation. Whenever there's an inflammation, the permeability, that it's important to maintain the fluid balance between the intracellular and the extracellular, will change. As a result of that, the blood will switch, and that will lead to the peripheral inflammation and edema. Now, where is the significance of that? Again, it's a restriction of the heart movement. And again, the patient will have chest pain that is not, it's usually pleuritic, it's not cardiac, and and we will understand. Again, we talked about that, how to differentiate it, mainly because of the timing. Usually it increases and gets worse when the patient breathes and so on. But as a result of the restriction of the heart, again, cardiac output can be low, heart rate can be low, muffled heart sound, and all that will lead to basically symptoms of low cardiac output, such as fatigue and pretty much symptoms like heart failure. So let's think about these manifestations. Okay, what is the problem? We have an inflammation that can lead to increase the friction. So the inflammation will restrict the heart and also will increase the friction, because now the layers and the lubricant that was preventing the friction between the pericardium and the myocardium is no longer there. So as a result of that, the hallmark and the most common thing that seen in 90% of these patients, what we call pericardial friction rub. That pericardial friction rub, again, it's as a result of inflammation in the pericardium leading to friction. The sound of that, you hear it with auscultation. It's a scratching, grunting, high-pitched sound. It looks like, it feels, sound like a leather, rubbing leather. And the important thing, I mean, remember we talked about before the pleural effusion, and in order to differentiate that from the pericardial, something had to do with inflammation around the heart, you will find that it has to do with the pulse, because the friction is caused during the systole when there's a pulse, right? Whenever the ventricles are contracting. So it has nothing to do with the breath. I mean, it gets worse with the breathing, but the timing of the friction rub, when you hear it using the stethoscope, of course, and use a diaphragm of the stethoscope, you will see that it has to do, it actually relates to with the pulse, or correlate with the pulse. Okay, again, the pain, it correlates with the respiration, but the pericardial friction rub correlates with the pulse. So the pain here usually is progressive and severe, depends, of course, on the degree of the inflammation. It's non-cardiac because it gets worse with the inspiration, coughing, or swallowing. Again, because of the inflammation and because of the friction. This pain radiates usually to the left side, but it goes to the trapezius muscles more than the arm, but it can go to the neck and the shoulder also, mimic kind of the heart, the MI kind of pain. But the differentiation is that, again, because this is more of a muscular skeletal pain, if you have the patient lean forward or sitting upright position, there will be some relief of this pain, which is, of course, that's not the case in cardiac. Nothing will help the cardiac pain other than nitroglycerin if it's angina or having a procedure by cardiac cath. But in this case, again, because it's musculoskeletal, the position can help. So remember, keep this position in mind, because make sure that this patient should never be in a supine position. The patient should be leaning forward or upright position at least. Again, dyspnea, and the dyspnea here is not related to lung issues, because lung arteries are clear. There's no problem within the lungs. But it's just because of the intrathoracic, the whole intrathoracic. It's because of the bleeding. it's because of the pain. Because the patients try to be shallow and breath and rapid breath. So because every time they breathe, the pain increases. And the restriction on the heart you can see that in chest x-ray. In the chest x-ray, of course, you can see that as a pleural effusion. You can see that in ECG, we'll talk about that. And you can see the manifestation of low cardiac output, such as low heart blood pressure. The pulse will be weak and thready, and so on. And again, so the signs of infection, fever, chills, and noise, and leukocytosis. You see that in the CBC, elevation of white blood cells. So again, this is the autopsy of patient with pericarditis. Now, just because of this is a very classical symptoms, you must know. This is a must know. It goes only with pericardial effusion, and it goes. Pericarditis comes from pericardial. So there's a match here: pericardial and pericarditis. Friction rub. So you need to know the auscultation, or you need to use a diaphragm of the stethoscope, and it should be in the left lower sternal edge, as if you're trying to listen to the APP to the valves. Okay, and it should be during end of expiration. That's when the friction rub, the maximization. And again, we said it correlates with the pulse, and it's best to put the patient in sitting position, leaning forward. That's how you can best hear it. There, as we said, it will be loud scratching, grunting sounds. It doesn't change with respiration, but it mainly correlates with the heartbeat, so it's a pulse. And I will put an audio later of how it sounds. The complication of the pericarditis. First of all, is the pericardial effusion, which is accumulation of fluids around the heart in the pericardium. Again, that will restrict the heart, and the classical manifestations of it will be basically affecting the heart sound. So distant and muffled heart sound. Blood pressure usually is normal within the pleural effusion. Now, the fusion is not as worse as the tamponade. Tamponade, when there's excessive accumulation of the fluids in the pericardium, and that will change the intrapericardial pressure, meaning that there will be high pressure leaving glycerol for the heart to refill. So that's when you will see that the heart is really compressed, and as a result of that, the heart the sound will be muffled and distant. There will be tachycardia and decreased cardiac output. And again, there will be narrow pulse pressure, meaning that systolic and diastolic will be close to each other because of the decrease in the systole. And the major thing also, there will be a JVD. The JVD has nothing to do with heart failure, and that's why we say JVD with the clear lungs. This is the JVD that's as a result of basically congestion that is of a heart related. Okay, again, because the heart is unable to receive the preload that comes back from the venous return. And so there will be accumulation and congestion of the venous blood. You see it in JVD. Again, one of the differentiation between JVD as a result of heart failure, usually when there's a JVD of heart failure, also there is a pulmonary edema. And while in this case, you see a JVD with no pulmonary edema, the heart sounds will be clear. And then the other classical manifestation in cardiac tamponade is basically what we call the pulsus paradoxus. Now, as you know, the pulse and the systolic blood pressure decreases within a physiological number during inspiration. Again, remember we talked about the relationship between the heart and the lungs, that when the lungs are inflated, that means that the heart will be partially compressed, and that's why the systolic blood pressure during inspiration is slightly lower than it during exhalation by 5 to 10. However, that is physiological and that doesn't cause any problem. But now, in addition to the inflation of the lungs, in addition to that restriction on the heart, that physiological normal restriction of the heart during inspiration, now we have more restriction. It's all the time. So these two restrictions, the normal physiological one from the lungs, and now the pericardial effusion, together will significantly decrease the systolic blood pressure during inspiration, and that's what we call it pulsus paradoxus. Now let's see. Now you have the patient come with this diagnosis. First of all, as far as history, you're gonna look and see from the high risk group what matches or what is the etiology. And then when you do your physical examination, you must know what is specific. So the most common symptoms that bring the patient to ER is basically it's a chest pain that's a pleural, and it radiates, so the trapezius gets worse with inspiration. So it changes with inspiration, so it's not of a cardiac origin. The second thing, a patient, 90% of the patient, they come with a pericardial friction rub, and now you know how to assess it, and now you know what the quality of that, and it's only causes when in the case of pericarditis. Again, the patient may have dyspnea and cough, as again, the patient has dyspnea because they're unable to breathe. They're trying to hold their breath, or their breath will be shallow and rapid because of the pain whenever they breathe. And the patient may have symptoms of infection like fever and chills and so on. Now, in diagnostic test, after we know the history of the patient, we suspect, again, if you hear pericardial effusion rub, 99% it is pericarditis. So we'll go to some of the diagnostic tests. One of the diagnostic tests is 90% of the patients, we look at their ECG, and they see you will see the diffuse or widespread ST elevation. Now you say, okay, well, ST elevation, I saw that in unstable angina, and I saw that in MI. So what's the difference? Difference here that this ST elevation, it's not because of coronary artery problems. It's because of restriction, and this restriction is affecting every wall of the heart. So what you will see is diffused, spread ST elevation. You see it in multi-leads. You see it in several, and probably every lead. Now, the difference between this pericarditis ST elevation and the ST elevation that's caused by an MI, usually it's in a specific wall. So if it's inferior, you only see it in lead 2 and lead 3, for example. If it's superior, and so on. But when you see a diffuse ST elevation everywhere, then this is most likely it's because of pericarditis. That's number one. Number two, if the patient has an ST elevation because of myocardial injury, patient will also have chest pain that's cardiac of a cardiac origin, which is not the case in pericarditis. Another thing is the troponin. Troponin might be elevated in pericarditis, but it's not as the same way as in the MI. Okay, so whenever you see a diffuse ST elevation in multiple, of course, in addition to everything that we mentioned, the patient comes with pericardial friction rub, patient comes with the chest pain that increases with respiration, and you see this finding in ECG. As you see, there's ST elevation pretty much in every lead, then that's a confirmation of pericarditis. Other diagnostic tests, we can do an echocardiogram. In echo, remember we said in echo we can see pretty much everything, and as you see, there's a pleural effusion and pericardial effusion. This patient had both, but this is what we're looking for, the pericardial effusion. You can clearly see that in echocardiogram, and of course, through echocardiogram, we can measure a lot of things that we mentioned before. Another thing, in chest X-ray, you might see a cardiomegaly as a result of the pericarditis, and also you will clearly see the pericardial effusion. And in lab work, if the pericarditis is caused by an infection, you will see the white blood cells elevated. Again, if it's acute and the patient is severe there's severe pain, and again the restriction affecting the circulation of the coronary or the coronary circulation, then troponin might be elevated. And what we also do when we do a procedure called pericardiocentesis, we'll talk about it in a little bit, but during that procedure, basically, as we did in the pleural effusion, we withdraw or aspirate the fluids that's surrounding the pericardium, and we can send that for culture and analysis to see if it's a microorganism, if it's an infection, or if it's a neoplasm, so we can see if it's cancerous or benign. Okay, medical management, let's just put the things together. So if it's infectious, especially bacterial, antibiotics will be prescribed. In pain, usually the pain, again, we don't have to give opioid in this pain, NSAID can help, but the major thing is to treat the underlying cause and decrease the inflammation, and that's when the pain will subside. Because of the effusion accumulation, until we get the patient to be ready for paracentesis, we can give them Lasix. And because of the restricted contractility, we can give the digoxin. Now, if it's severe, we can give dopamine. Now, as far as nursing management, first of all, as always, you need to identify who's at risk, and you need to teach them to promote the prevention of them. Then the other thing, you need to understand the clinical manifestation based on your understanding of pathophysiology. And another thing, you should be able to, again, identify and make sure that you can know what the clinical manifestation of common complications. So we said the two major common complications of pericarditis is pericardial effusion and cardiac tamponade. So you need to understand the clinical manifestation that differentiate these two conditions. Another thing is you are expected to know how to perform the physical examination and be able to interpret the findings and mainly how to differentiate fractional precardial friction drop and muffled heart sound and pulsus protaxis. Now, as far as management, again, you need to understand and analyze the diagnostic procedure. What is classical for pericarditis, for example, the diffuse ST elevation in ACG. As far as pain management, the major thing is to have the patient upright position, never put the patient in supine position, and NSAID will take care of the pain until we are able to perform pericardiocentesis. And I will add I'll add a YouTube video of pericardiocentesis. So, and you need to see that, so you need to know exactly what happens in this procedure.
Oh, okay. This is
the other layer of the heart that can be.
This readers is the shortest. The heart is the very crust 啊，就是给我们展示了什么？展示了我们心脏的它的生理病理啊，它的一个因为循环系统是我们儿科学里面比较重要的一个系统，也是你们内科学的时候，循环系统是比较最难的。啊，等一下，我把这个视频发到群里面去，你们大家回去以后可以下载或自己看一下啊。所以说这节课叫 This class where is the 提前预习了啊，就提前预习的这个心脏的一个那个。我再通知一下，周四上午的1、2节课叫儿童保健学，我们到时候也还是以线上为主。为什么线上上课？是因为你们上课的那个教室没有空调，然后天气又比较热，所以说叫我们线上上课。下个星期的话，天气比较凉快了以后，我们肯定会去教室给你们上课 ，OK？ 就教室上课啊，就302，我们到时候会去教室上课。我再给大家说一声，我是你们的儿科教学秘书啊，我的这个电话发给你，你们的那个班长叫李一彤啊，有我电话，我到时候刚才把电话也给你们发了，你们到时候是见习还是有老师没来上课啊，有什么事，你可以给我反映，给我打电话啊，我再通知，我会跟他们代课老师说一声啊，就是说有些代课老师你们觉得提一下什么意见的那些都可以的啊，我们会改进，好不好？
好的，老师。
我把这个视频等下发到群里面去，然后你们在群里面下载后回去看一下。我后期会有一些陆续有一些视频啊，我们是一边讲，然后一边这些视频给大家一起。为什么？毕竟我们英语啊不是说的那么标准，大家可能听起来很别扭啊，这是因为我们那个英语不是特别标准啊，但是我们能尽量的有一些英语能给你们讲清楚的讲一下，好不好？主要是这些。我等一下把这个视频发到我们那个群里面。